Health Protection Research Unit for Modelling Methodology has developed new mathematical, computational and statistical tools for analysing infectious disease data and interpreting the patterns in those data, for understanding the transmission dynamics of infectious diseases, by which I mean how diseases spread from person to person, which clearly varies dramatically between different pathogens. What are the risk factors for spread? What are the risk factors for severe disease? And that can then, in its own right, inform the design of control policies. A very small part of what we do, because it's intrinsically extremely difficult, is trying to make predictions about trends in disease. More commonly, we do, though, make predictions about the potential impact of control policies. And so the motivation for this health protection research unit has been to really develop the sort of tools which will allow Public Health England and the NHS more generally to exploit the data revolution which is going on in healthcare in the UK and globally, in terms of the wealth of electronic data on patient records, many of you will be aware of, and new genomic data coming through, but also data which is increasingly digitally captured on the demographics, the geography of populations, all the way from Google Maps to Twitter feeds and the like. Integrate data on health economics and on environmental factors which often underpin the etiology of disease and the severity of disease. And in selling our proposal to NIHR and indeed to our colleagues more generally, we argued that really exploiting these new data resources and these requires new methods and new capability. I mean, big data is a slightly hackneyed phrase nowadays, but it's certainly true within the public health space. And we need tools which really can draw on multiple disparate data streams to get the maximum information, called data synthesis or evidence synthesis, because data on its own tells you very little. You need to synthesize out the key points to inform control policy planning and interventions. And I won't go into the details of this, but the structure we put in place, the key research themes, span surveillance data, statistical inference, which is trying to understand the patterns in data and test hypotheses, simulation tools to simulate epidemics in populations and test in a computer different intervention strategies, and also a strong element of integrating new genetic data to understand pathogen evolution. The Health Protection Research Unit brings together three of the strongest groups in mathematical analysis and modelling of infectious diseases in the UK, our own at Imperial College, but then PHE over many years has invested substantially in modelling and related methods, both in Colindale and in Porton Down. And each of those groups has a different set of specialist skills they bring to bear, and in total we have something over 100 researchers involved in the Health Protection Research Unit. Some examples of the sort of software tools we're developing as part of the HPRU. These developed by David Allison and his colleagues, who leads one of the key themes of the HPRU, which is to develop new software which takes advanced methods for analysing infectious disease data and turns it into user-friendly tools for healthcare professionals and public health officials to use. So one of them is EpiCollect, now used, been developed for over many years and being further developed now by David for use by PHE in epidemiological data collection, in outbreaks and routine data collection. This is a tool which really runs on mobile phones and allows digital capture of data which used to be captured on pen and paper and then entered into computers later. The advantage of using mobile technologies is that data you record as part of, for instance, an outbreak investigation or a research study is immediately sent to a central server and immediately available for access. This is just actually an indication of one example application, but there are many, many others. In other work, again led by David's theme, is developing powerful software for the visualization of infectious disease data collected in hospital outbreaks. And this is bringing together clinical and epidemiological data on location, age and characteristics of patients, symptoms with genomic data, which allows you to track pathways of infection within this sort of environment. But what I wanted to spend a few minutes talking about is the work which has actually dominated our every waking moment really for the last 6 to 8 months, which is working on something which is not principally a UK threat, though it does pose a health protection challenge to the UK, but has been a huge priority for the UK government in its global citizenship role in guarding public health, and a major global health challenge around the world, and it's the Ebola epidemic in West Africa. And we have been one of the leading groups, and indeed we're the first groups with access to data from all 3 countries, who've been analysing the pattern of spread of this epidemic and informing the World Health Organization, the UK government, the US government, and the governments, of course, of the 3 worst affected countries, Sierra Leone, Liberia, and Guinea, on control measures and how to get on top of this catastrophic epidemic as quickly as possible. This shows you the epidemic curves of the Ebola epidemic in those 3 countries. It's hard to see the scale, but we've had a total of 20,000 reported cases so far. The true scale of this epidemic is many times larger, almost certainly. There's been a lot of underreporting. It has been a catastrophic event for West Africa. Ebola, as I'm sure you know from the media reports, is one of the most lethal infectious diseases in the world, with a case fatality rate, the proportion of people who get it who die, in excess of 50%. The sort of things we've been doing are analysing and visualising the spatial spread of this epidemic in West Africa, understanding the patterns underpinning what you see on the screen here, the risk factors for spread, trying to understand why some districts have been much more worse affected than others, and tracking in detail. We have very detailed data on individual cases. What are the things which, in terms of the interventions being put in place, which work and what doesn't work? And so one of the key things we've been looking at, for instance, is information which is collected, very difficult information to collect given the circumstances, on what people say about the contacts they had which might have led to their infection. New Ebola patients coming to Ebola treatment units in West Africa asked a lot of detailed questions about how they might have been infected, and we can take that data and ask, what does it tell us about the real context of transmission, the places which are risky and we should be targeting? So people report contacts outside in a funeral context, because we know funerals in a West African context are a big risk for transmitting Ebola. There's a tradition of touching the body when you're paying your respects, and that poses a big transmission risk for a disease like Ebola. And non-funeral contacts in the community. And the sorts of things we can find out from these data, and I'll just highlight one individual trend. If we look at what people report in terms of the ill people they've come into contact with, well over half of those people are close family members. And this is a particularly tragic epidemic in the sense of what you see in the line list in the data we analyse is often a father becoming infected, then a mother, then 2 or 3 weeks later the children in the same family. And we can target interventions at households, we can target interventions at funerals, and we can target interventions at particular stages of infection. And one of the key issues has been hospitalising people as early as possible to prevent transmission, to try and accelerate control. As you saw from this original plot, we are doing quite well in terms of control. I should emphasise that these are the suspect cases. The confirmed cases in Liberia are now a handful. Most of these suspect cases are not later confirmed, but we still have a long way to go in terms of what's happening in Guinea and both in Sierra Leone. It's going to be many months before we fully bring this epidemic under control. We're providing weekly situation reports to the UK government, to the World Health Organization, to US Centers for Disease Control, to tracking the progress of this epidemic through time and making short-term projections to inform health planning on the ground. And I hope that illustrates really what our key goal, and we have many technical and scientific goals for this HPRU, but really our key goal is to make a difference. We're not involved directly in clinical care. None of us, or very few of us, are actually clinicians. What we do is provide information to public health officials, to policymakers, and to clinicians, which hopefully allows better targeting of resources for more effective health protection. And this is really a passion for us all. That's me sitting next to actually Admiral from the US Public Health Service, based at CDC in Atlanta. And so what we're trying to do with this HPRU is build on actually a very strong base in the UK in this area, but enhancing our capacity to make use of the data I talked about on the first slide. So a lot of that involves putting software tools together which puts these powerful techniques in the hands of non-experts, but also training the next generation of researchers in this field. And another key element of what we're doing is providing support for the 12 other health protection research units. Thanks.